Stuti Jha is an associate professor of economics at Rowan University. Her research focuses on labor and health economics, and specifically on physician labor market outcomes and medical education. Stuti, thank you so much for taking the time today.
Hi, Joe. Thank you for inviting me, and I'm really excited, looking forward to having this conversation with you. So, thank you.
Awesome. Well, I'd love to start just by asking about what you see as kind of the current trends at the intersection of labor and health economics.
That's a good question. So we see a lot of, I mean, right at the outset, there is projected physician shortage that we're expecting. There's a report by the AAMC, American Association of Medical Colleges, that projects a shortage of almost 85 or 86,000 physicians by the year 2036. That's a huge number, and that's like the trend towards physician labor market in particular. And it's just like, again, it's a two-way thing. It's, again, we're talking about new entry into the field, and also about the attrition of practicing physicians. So that's another aspect to the physician market challenges that we are facing right now. I'll just talk about the attrition first, and then we can talk about, because I know we'll talk about the entry of physicians in the labor market later on. So the first thing would be that there is a high physician burnout, right? That has been a big research question and a challenge for the medical community in general. And it sort of was exacerbated by COVID, the pandemic, because the physicians, especially the ones who are working in primary care specialties, they were just like, it was so challenging to work during that period. You see a lot of physicians just leaving clinical practice. So there are like two kind of thing, right? They're either leaving clinical practice altogether, or they're moving within a hospital setting. If they're employed by a hospital, they're moving more towards administrative roles. So people who are altogether leaving clinical practice, they are going to work for, let's say, an insurance company or a pharmaceutical company. What are the advantages for them? First of all, they don't have to deal with, there are challenges to work, especially as a hospitalist, right? If you're working in a hospital setting, you have to deal with a lot of administrative bottlenecks. There is a lot of physicians do mention, this sort of weird, not but this difficult dynamics with some patient population or the family members, and sometimes they feel unsafe to continue working in a hospital setting. And the biggest thing is just like in many cases, dealing with insurance companies, because you as a physician want to do what is right for your patients, but then you have to, a lot of those things are sort of stopped by insurance companies or not approved, and then you spend most of your time just dealing with that instead of actually treating the patients. So all of those things sort of come together and are like leading causes of physician burnout. And then they're like, okay, I'd rather just, and also, if you're talking about primary care physicians, they're not paid as high as some of the other specialties. So like, I was just looking at the average salary of a family medicine physician in the state of New Jersey. It ranges from 220 to 260, which is almost like $100,000 or $150,000 less than what a cardiologist earns. And if we start talking about neurosurgeons surgeons or plastic surgeons, it's almost like they're earning more than double in many cases. So that's another thing. So if they get a job at an insurance company or at a pharmaceutical company without all of those hassle, and they actually get paid more, that is a lucrative option for them. And especially this is true for physicians who are closer to retirement. That's another. So that's jumping on to another problem with retirement in physician community, because almost I think AMA statistics show that almost 20% of our physician workforce in the US are above 55. So they're
Mm.
close to retirement. That's that's a scary number. So if they all decide to just, you know, retire within a span of 5 to 10 years, we are talking about a huge shortage in that situation, right? That's one thing. The positive things, especially for primary care, we do see a more sort of an increase in the use of physician assistants and
Mm.
nurse practitioners. That can, and another the other thing is telehealth. Telehealth is we in US we are still not using it as much, but it is something that can actually alleviate this problem to an extent.
So within those those three roles you mentioned, or the physician assistant, the nurse practitioner, and telehealth, are we currently able to meet demand right now, or is there currently a shortage for physicians even with those new
Yes, there is.
things?
There's another projected shortage for nurse practitioners also.
Hmm.
So again, these are a lot of these healthcare, workforce um, segments. They are heavily dependent on immigrants. Okay, so whether we're talking about physicians or we're talking about nurse practitioners, a lot of them are foreign born or foreign trade, and they move to the US, they get all their licenses, and then they practice. So we are, again, in those cases also, we are not seeing a great sort of, you know, uh, supply increase where they are able to meet the demand. However, in physician assistant case, we are seeing a lot more physician assistants in the market. And that does help. They help in hospital settings by helping, a lot based on their specialty. Again, they have specialties, right? So they can help the doctors in surgeries, they can help with paperwork, administrative work, all those things. And there is like this whole idea where, because there's also, like, when we're talking about physicians shortage, you also have to understand that there is also a geographic component to it, right? Rural areas, and especially rural areas and some of the underserved areas, which could be in densely populated city like New York or Chicago, where you have a whole bunch of people packed in 1 square mile of area, and we still don't have enough physicians to take care of all of them. So there is this discussion about, at least because the licensing procedure and the processes are easier relatively. Again, no, becoming a nurse is not that easy in this country, but it's still relatively easier than being a physician. Uh, so can we have more physician assistants and nurses and telehealth opportunities available in these underserved areas, whether it's rural or urban, densely populated areas? And if yes, what do we do to, make sure to bridge that gap? If we're still not addressing all of the shortages, we're not. But that is one way of doing it. Like um, yes, that's it.
Well, so you mentioned both the attrition of physicians and also getting more new physicians
Hmm.
entered into the profession. How do we incentivize or get more of these uh, young people to navigate towards being physicians, or also
Yeah.
the nurse practitioners and physician assistants as well.
Yeah, so, and that is like the one big factor that impact all three of these fields is basically cost of getting that education and getting the licenses. Being a physician, especially, so think about it. You spend almost, depending on what residency, what specialty you are in, you're spending almost 10 to 15 years just on education, higher education, post high school education. You are dedicating the some of the most productive years of your life to training yourself. So all of the returns to that education is sort of, backloaded. So we start earning, physicians start earning, making money in their mid 30s, and they actually start flourishing in the 40s and in 50s. Okay. If you have made medical education so prohibitively expensive, how are they ever going to get rid of all the student loan? Because I think the average cost of going to medical school is 200,000, right? And then residency, depending on how long the residency is, it's not that you're making any money, you're just barely making ends meet, because it's like 60,000 or $70,000 if you are somewhere in Northeast for a year, right? That's barely enough to cover rent in these countries. By the time, like, suppose you're starting a residency, you're 27, 28, a lot of these physicians are already married by that time, right? So imagine taking care of a family in that kind of money, right? So one aspect, and that's true for physician assistants also. The cost is not low at all. It's very high, although I think the overall schooling is only for 2 years. So that sort of helps them in the sense that they can get into the workforce earlier, and then they can start paying off their debt much sooner. Compared to that, the nurse practitioners, they again have a much longer licensing process. And again, sort of some of the similar issues that we see with the physician market. And another thing is, I think it's like way more difficult to become a nurse because the rate of failing, no, what is called failure, or failing out of nursing school is quite high for nurses compared to physicians, like medical students and physician assistants. So all of those things are sort of the barriers to entry for any of these healthcare workers. So one thing would be, having there has to be some level of government involvement in this situation. How do we make medical education? How do we subsidize medical education? In many of the developing countries, you will see like a lot of physicians who and nurses who are entering US to practice medicine or nursing. Basically, they studied in their home country on subsidized education, and then they sat for USMLEs and got here, or whatever the equivalent for nursing is. I don't know much about that field. So yeah, so federal subsidies to sort of ease the cost of going to school is one thing. um, Other license residency is like another big bottleneck, because the residency numbers are usually capped, and they are dictated by like federally funded residency slots that's covered under the Medicare program. And in many cases, so especially this was like I think in the 90s. Before that, they weren't so strictly regulating the residency slots, but since the mid 90s, they because there was this paper in the 90s, or some fear in healthcare system in the US, that we are taking in way too many physicians, and there could be an actual surplus of physicians. So then they passed this law, which is the Balanced Budget Act of 1997, to put a cap on these residency slots. So now the issue is, so there are the issue, right? Just increasing medical school caps will not, or opening new medical schools will not help. Because if those students cannot find residency positions, because you have to be a resident and complete your residency to get licensed to be board certified, right? So if there is a mismatch, there are way too many medical colleges, but not enough residency slots, where will those students go, right? What will they do after spending like almost like $200,000 to $300,000 on medical schooling? How are they expected to get anything in return if they're not able to get residency positions, right? And a lot of, like, almost like 90 to 95% of residency slots are federally funded. So there is a bill right now in the Congress. I actually have not sort of tracked it, but I think it was it was a bipartisan bill. I think it was introduced in this last year sometime, and they wanted to increase, or they want to increase the number of residency slots by 5,000 every year. Okay, so additional 5,000 slots from now for the next whatever foreseeable future, and that is in response to that AMC report of physician shortage of around 86,000. So they are doing certain things to sort of uh, address these issues, but we still don't know whether that's enough or not. And then foreign medical graduates are, again, they're the same problem, right? You have this global physician population who are ready to maybe move to US and start practicing, but if there are not enough residency positions, how will you do that? You usually don't have any option. And many of these foreign medical graduates are actually not immigrants. A lot of them are, especially like in medical schooling, a lot of them are American citizens who could not get through medical schools in the US. So now they go to medical schools in Caribbean or in Mexico or somewhere else, get their degrees, and then they want to be able to come back to the US, get licensed, and practice. So that's like, it's a little complicated the way, the whole system is sort of set up.
Yeah, so the residency matching process, I want to talk a little bit more about so there are these additional spots that they're talking
The
about.
bill, yeah.
So that would be
5,000.
5,000 additional spots a year. But you mentioned earlier there's like a projected gap of like 85,000 by 2036.
Yes.
So even 5,000 a year wouldn't
That's
be
not enough.
sufficient.
Yeah.
So
That's not enough.
how does this residency match process influence a physician's career choice, or somebody who's thinking about this process and all the different dynamics? And there's also the shortage of residency positions at the same time. How does the residency match process influence physician career choices?
Yeah, so I think the way the batch process is set up, I think it's quite efficient the way it is set up, because it's based on the rank choice of both the hospitals and the medical students, the applicants. And pretty much, if I rank an applicant, I'm a hospital administrator and I rank an applicant pretty high, and they rank me pretty high, we are going to be matched. Okay, so that the process itself is quite efficient in my opinion. The problem lies in, the first thing is a lot of there is more demand in primary care anyway. So a lot of residencies, there are more primary care residencies compared to, other specialties like neurosurgery, cardiology, and all those things. However, we are talking about a patient population that is quite sick. we as Americans are not the healthiest of people, right? We have the highest degree of like diabetes and health disease. And we're also an aging population, which is sort of true for most of the developed world now. There's like more aging population. But anyway, so there is that thing where a lot of these residency slots are for primary care, and even as a medical student, you may dream of being a surgeon or a cardiologist, but the, if you only apply to cardiology residency or surgery residency, your probability of being matched is quite low because those are the most competitive residencies, right? So it's also like, even though the process is very efficient, but you also have to play the game, right? You like if after high school you're applying to colleges, so you always have a safety school, right? You want to make sure that you land somewhere rather than just applying to Princeton and Yale and getting upset that you didn't get anywhere. So it's an applicant, you have to make that choice and you have to figure out what is the right kind of mix for you. So that's another game. If you apply for a primary care, so a lot of physicians, what they end up doing is they go through the route of primary care. So they get matched in an internal medicine or a family medicine residency, and then they do fellowships in subspecialties. Okay, so if you have a pediatrician, they may end up doing a fellowship in, let's say, oncology. So they become pediatric oncologists and so on and so forth. So that is one way in which, some of these medical students get around this idea. But then not all of those things will still be. You'll still, if you want to do neurosurgery, you still need to do a residency in neurosurgery. You can't, like surgical residencies are extremely difficult and competitive to get. Now again, in terms of residency, unless as you said, even after we increase residency slots by 5,000, that's still not enough.
Yeah.
So that is why having PAs and nurse practitioners and all those, focusing on them also is a good choice and a good strategic policy move. Another thing is sort of what is the right word? Encouraging telehealth appointments and accessibility to people, right? So that is also another way of, because a lot of times if you're looking at patients who are very sick or very poor, okay, if they are setting up an appointment with a doctor and going to see them, if you are very poor, you actually have to take off from work, right? You're losing the at least half a day of wages, okay? And then transportation, you're spending money on transportation, especially if you live in a rural area or whatever, where transportation could be really difficult. So if for those individuals, telehealth is an option, which again, Commonwealth Fund is agency, is an organization that does cross-country research on healthcare systems, and it focuses mostly on developed nations. And it's like some of the countries like New Zealand and UK, not UK, I think it's New Zealand and one more country, I don't remember. They have Germany, they have very high rates of telehealth appointments. Okay, almost like 35-40% of their overall interaction is virtually. And US ranked at the bottom. Okay, so US, and this is 2024 report, so it's not super old. US ranks pretty low on that chart. So that it's just, increasing access to care. That is one thing where we struggle. We have to make sure that people can access care. In terms of very sick population, telehealth could, because if you're very sick, you do need that face-to-face or in-person interaction. So there's another, but that is, I don't know if it will work in the US healthcare system, but in some of the developed countries, there is home healthcare is easily available, and physicians actually do make house calls, which is almost like non-existent in the US, physicians making house calls. Now, again, if in those cases, again, if we don't want, if physicians are, too tied up, or they have there's like too much demand on their time, we can train physician assistants and nurse practitioners to make house calls. Now, there are like genuine issues. There's a safety issue going into someone's house and all of that stuff. But I'm sure there are ways in which that can be worked around, right? So these are some of the issues that we need to sort of address, and some of these are not like um, improving access to telehealth should not be that difficult.
Yeah.
About it, right?
Yeah, I'm curious about the way that other countries have addressed demand for physicians. If there are examples that you can point to where other countries have faced a shortage as well, or they've
They
just
all actually, I was just reading about it, and pretty much all the countries are facing the same. They have, because most of the developed countries, sorry, they're following the same path demographically, right? They have aging population, and in many countries, US being the exception, there is universal healthcare or government funded healthcare, or some, like there's like some private public partnership in some countries, like I think Germany has some, but overall it's government funded. So in a way, if you have one, again, I'm not like advocating for socialism or anything, but like in macroeconomics also, we have this thing of central planner, or someone who, or social planner, who there's like one body who sort of looks at everything and decides what is to be done. Okay, and that's just like a theoretical perspective on things. So if you have a body, a federal body that can do that and figure out a way, so that's what some of these countries have done. Like UK did that for the longest time, but with Brexit and how poorly the UK British economy is doing, I think they have now looking at serious shortages in their overall physician market. Australia is one which has done well. Australia, but then again, there's mostly foreign physicians, okay, international medical graduates who have moved to Australia and are practicing there. So I think Australia has the highest number of physician per thousand people in the OECD countries. I think it's like 5 point something, and US is 2.37. So for every 1,000 people in the country, we have 2.37 physicians, whereas Australia has almost like little over 5, just over 5 physicians per 1,000.
So why is that? Is that because they've just allocated more funding to
Yes,
more?
more funding. There are more, I think the licensing requirement is easier there, and they're more open to foreign physicians to get into the market and practice there. So it has to be a true two-pronged approach, right? How to increase domestic supply. But again, domestic supply is not going to change overnight, because it's, you need more medical colleges, more residency slots, more teaching hospitals, all of those things. In the meantime, so if you want to increase the incoming foreign students, that could alleviate some of the problems, but not everything, because as we mentioned earlier, that residency slots are still fixed. So we have that issue. So again, in the way I think is making sure that there are more physician assistants at least, and more nurse practitioners, and like midwives, like we don't do well in maternal health. Okay. Our like the women in the US have a very high chances of dying due to because of complications due to birth, at a very high rate compared to any other OECD countries. Okay, so a lot of countries actually have midwives and birth doulas. There's sort of like, they're not really midwives, because midwives usually come only for the delivery process, and they may be around for a few of those things. But the birth doulas, they actually provide sort of counseling also, and they're there for the expectant mother. They help them through the process of pregnancy and delivery. So those are the things, and US is seeing some increase in those kind of professions also, but it's still not mainstream. Like in UK, midwives are mainstream. Okay, there are like, we have to have this middle tier of healthcare professionals. We need to promote them, so the stress on the top tier, which is the physicians, is reduced.
So there's I'm hearing a few different things. It's not just the physician's assistants and the nurse practitioners, but it's also thinking about all of the different positions and making sure that they're able to kind of take stuff off the plate of physicians, so that we can add more capacity. And maybe then would the 85,000 number you mentioned come down a little bit, or?
Yeah, it'll again, like, yes, in the sense that if I just have like a headache, or I'm just sneezing, or I know I have flu, I just need to get a prescription or something. I can just, like, now it's like through private insurance, it's easy, because you can request a telehealth appointment and get that prescription. So if that is accessible to a lot more people, I don't have to call my doctor and go there and actually see him in person or her in person, right? So that, because of that, there will be sort of that, it's like that the pressure is building on the top, and it will be like that valve that let the pressure loose. So that's how we do it.
Yeah. So I wonder if you could describe how you see things moving forward, thinking about the future and maybe a 3-year or a 10-year time horizon, or maybe looking at the
3 years is not, yeah, 3 year is not enough, I mean, actually, I don't know, because so much is happening right now politically. So who knows what the next 3 years bring. Um, although if the bill that is going to address the graduate medical education, it's called the Graduate Medical Education Working Group, I think. If that is passed, that will definitely be, so we will be hiring like 50,000 new 50,000 new physicians in the market. That straight away reduces the shortage by 50,000, which means we are like still lacking 36,000. But then if we can improve the retention rate, right? And again, I'm not like, I don't want to start talking about it because I'm not too familiar. I'm not really a tech person. But there is a positive way in which AI can be incorporated, or like, just technology can be incorporated in the healthcare system. So the physicians who get so annoyed by doing paperwork and billing and all those things, at least AI can take that stress from them, and the way AI is developing, the rate at which it is developing. So I'm hoping at some, pretty soon that will be the case. Again, I don't know whether it will happen or not. So if that ends up being happening, then, maybe we are able to retain more physicians. The attrition rate will reduce, right? So that will also help. Another thing was, I had one more point. I forgot about this particular thing. I completely forgot. But then again, and then encouraging or increasing the supply of that middle tier, right? The PAs and nurse practitioners, all different kind of healthcare professionals who aid and help in providing services. If we increase all of those things, that will be helpful. There's something called like death doulas also, right? So they help people in the in their end of life, process, just helping them ease through that. So a lot of those things. And then actually, somebody, like, this was very interesting. This is again a little bit off, not off. It's related to this, but I think I was talking to someone, one of my colleagues at the Cooper Medical School, and they talked about how they hired a psychiatrist or a therapist for patients in not ICU, but like patients who had just gone through surgeries and everything. So they would like just the way doctors make rounds, those therapists would also go to these patients and talk to them. And that really improved the overall patient experience of their hospital visit. Now, if patients are more satisfied, that's going to have an impact on physician-patient relationship also, and that will take care of some of that. Now, this is like one-off thing that they did. And they were quite happy. I don't know the exact details of what they did, but I think this was like 2 or 3 years ago I had that conversation. So this is pretty much, I think, the gist of what they did, and it helped the patient experience of their hospital stay, which in turn also improves not just physicians, but all the nurses that are working, the physician assistants, because if patients are not happy, they will take it out on the people around them, and unfortunately, they are our healthcare workers.
Yeah. Well, it sounds like there are a lot of things that are interconnected and
Yeah.
influencing physician retention and the number of physicians we're able to attract and retain. But I really appreciate you taking the time to talk, and I'd love to continue the conversation down the road. But thank you
Sure.
for sharing insights and yeah, I appreciate it.
Thank you, Joe. It was an interesting conversation, and thank you for contacting me once again and giving me this opportunity. I appreciate that.